Good morning, everyone. So my name is Fiona. I'm here with my colleague Francis, and we are both members of Voices for Care. So many of you may be familiar with Voice for Care, but some of you may not. So I'll just give you a little rundown of who we are. We're a volunteer group established by the Institute in 2013, and our aim is to help inform the work of the Institute, influence the wider palliative care sector across health and social care, and support palliative care education, research, policy and practice. So we currently have 63 members, and they're made up of people who have an interest in palliative care, carers and former carers of people with palliative care needs, and people with life-limiting conditions. So as you can see, Mary spoke earlier on about the impact that Voice for Care members make, and as you can see, it's all about the lived experience. And as researchers, and I'm obviously biased, but as researchers, we feel the lived experience is invaluable to you. So we are involved in a wide and diverse range of opportunities, and one of those is what Francis and I are going to talk to you about. So we held a focus group in relation to psychological, social and spiritual needs. We held it on Monday, the 14th of October, and we had 9 Voices for Care members in attendance, and 2 members of the Institute, and we had an excellent facilitator. So the discussion centred around 3 key areas: spiritual, social and psychological support. And then we disseminated that among the wider Voice for Care membership for their comments, and they were incorporated into the final report. So what we found came out of the focus group was that it kind of divided into 2 subgroups as such. So we had the recipients of palliative care, and then we had those caring for people with palliative care needs. And then we could further divide the recipients into sharing their own experience of receiving palliative care and their psychological, social and spiritual care needs being met or otherwise, and sharing their observations of their experience of their loved ones. And then we had those caring for them, they shared their thoughts and experiences. So this is just a lovely quote that Francis brought to our attention, and we thought we'd share. "You matter because you are you, and you matter to the end of your life. We will do all we can, not only to help you die peacefully, but also to live until you die." So we just thought that was really beautiful. That's Cicely Saunders there. So in terms of our spiritual needs, Barry has spoken there and has touched on a lot of what I'm going to actually say. And what came up for us really is that for everyone, it's going to mean something different for everyone. And that's really something we need to take into consideration. It's highly individual. There's no one size fits all. So if we get it wrong, and this is a direct quote, it can spoil their experience of death completely. And subsequently, the impact then on the grieving process for those caring, it really can be detrimental. So the quotes themselves, they really speak for themselves. Finding out what the person's wishes, it seems so important in this, because you could come in with the wrong set of tools, completely thinking that that's what the person would want. I think it is so important to get the person's view as to what their needs, their spiritual needs at end of life are. And then this quote now, which I think is very impactful. All the quotes are impactful, of course, but this one in particular stood out for me. He really was calm and accepting that he is in end of life, and he died peacefully. And he was dying praising God. It helped him to relive the pain, the grief, the regret. And he died so peacefully for me. And this is the line: "I think spiritual needs is as important as painkiller and pain relief and everything." So Barry spoke earlier there about it being an integral part of total care. And we spoke in our focus group that medical care reaches a certain point, and then spiritual care can actually become more important at that stage, which brings us on then to this point that came up when we were talking about the spiritual needs, that your spiritual needs can change as the person nears the end of life. So at the start, they may have certain wishes and needs, but that can change as they go through. And so we need to revisit it throughout the process. So people who may not have had a strong faith or religious beliefs may seek spiritual comfort as they approach the end of life. My father hardly ever went to church. My mother maybe on a Sunday, but neither of them were really fussed. You know, I have my own sort of views, but I was very careful with them to respect theirs and not to push anything of mine, especially in those fragile kind of last moments. But interestingly, they both really wanted the prayers, they wanted to receive the sacraments, they asked for it. So that's, you know, very, very important to bear in mind that those needs can change. So, again, sorry, I keep referring to Barry, but you just touched on so much, which is great that we complement, the work complements it. The spiritual care witnessed and provided while working in the healthcare settings. So this member spoke and said, I spent 17 years on night duty, encountered a lot of sudden and unexpected deaths from all kinds of conditions, including palliative care. It was the priest or the religious person for their denomination, reflecting, saying prayers. And then sometimes, if it was quite sudden and we couldn't get religious support in, I would have had to deputise myself and say prayers. And I often used to carry a little prayer book with me, and people would say, oh, thank you so much. Because as we know, 2, 3, 4 in the morning, people are not always available, and we need to be adaptable to meet the needs. So this next quote, to give you a bit of context to it, it was the member, a Voice of Prayer member, was working a night shift in a hospital. The patient hadn't slept for 4 days, was very restless, crying and shouting. So I was thinking, he's not sleeping. The more he's shouting, I feel pain in my tummy. I feel like, what can I do to help him? And lastly, I was thinking, maybe he needs something to calm him. So she spoke to the patient's son about his faith. And she then put a prayer on her phone and she placed it beside his bed. And it helped. He really had a nice sleep. And morning, like 7 a.m., he died peacefully. How can I help this person to relax? And then finally, I'm able to help him. So that was very important to her, it was very important to the patient, and it was very important to the family. So Frances now is going to share with us the psychological and social aspect of our focus group. So I'll hand over to you there now.
Thank you. Thank you for this opportunity. I'd like to discuss the social elements that came up in our focus group. Again, about individual wishes, needs and expectations. It's going to be so individual, it's going to be so unique to every person. One contributor said that their loved one really didn't want to meet anybody. They felt shy, they felt inferior, they felt weak. Are we listening to these voices? Are we listening to these feelings that are being expressed? He was not able to take care of himself anymore, so clearly there was an aspect of pride here that he felt was being compromised. And because of that, he really just wanted to see his family. He wanted to be with his wife. He wanted to be with his children. So when we're looking at social needs, I think we need to go to quite deeply how the person is perceiving themselves as they're going through their end-of-life experience. I thought that was quite profound. Another thing that came up when we were talking about social supports was where somebody wanted to die. And I was thinking of this because you ask us the questions and we don't always have the answers that tick your boxes. You have boxes you want us to tick. So I felt, well, is this a social issue? And the people that were giving their contributions in this focus group seemed to think that it was. They said, we need to know where people want to be cared for, where they want to die. Maybe this is a social issue. It did come up under this team. One contributor said there was a lot of conflict between the medical teams around her decision to end active treatment, and that was really difficult. This caregiver, this daughter, took on the role of being an advocate and found that very hard. And I think, again, as we listen to people's voices, we have to imagine for somebody who doesn't have medical or nursing or caring experiences, when they're put in this place and they're meeting people with years of experience and years of expertise, there can be an imbalance there. It can feel quite daunting, I imagine. So I'd like us to be mindful of that. They did say it can be difficult to access the social supports for people who want to move to a different place for their end-of-life care. We need to look at that. And sometimes our medical needs are met very well, but our social needs are not. And then we moved on to practical needs. How did we move from social to practical needs? It came up in our conversation. People talked about the difficulty in accessing practical things to care for somebody at home. It can feel like a struggle. We look at these words like struggle, overwhelm, traumatic, stress. These came up in our conversations. It can feel like a struggle to access things for comfort and care at the end of life. One of our contributors said, I remember speaking with the liaison nurse. It was a new experience for me. What you're so experienced at is a new experience for us. A new experience for me, there were forms to be completed. There was quite a bit of a reference to forms to be completed as well. It might happen that you'll get a commode, you might get a pressure relieving mattress, you might get very practical things if you talk to the right person and if you complete the right form. So again, it was an element of, for some people it worked very well, for others there was a lack. In some cases, families don't know what's available. They don't know what a pressure mattress is. They don't know that their loved one needs one. We are quite reliant on you to help support us in these very pragmatic comfort needs. We depend on the professionals to take control and to do things for us, to make things available for us. We depend on you. You have the skills and you know what can be accessed. You have this training. This is where the professionals come in. If you get a bad professional, as one person did in our group, it can ruin the whole thing. No pressure, anybody. So, let's look at the pace and progress of illness. This came up as well. How can we make things available to people in a timely manner, whether it's spiritual, psychological, or social supports, or indeed those pragmatic things that might be needed. We ask, what is the pace of a person's illness? What is their illness trajectory? For some people, there might be very little time to make suitable arrangements to maximize their comfort, maximize their living and dying experience. Okay, let's look at psychological supports. We do ask that you ask the right questions at the right time, in the right manner, to the right person. We need to ask both the person and their family and their caregivers. Are they anxious? Are they afraid? Are they sad? Are they actually feeling quite content at this time in their lives? Are we looking at what might be going on for them? We do ask that you ask, okay? Some people did feel that the focus is on pain relief alone, but they do say that the psychological, social and spiritual needs of the person receiving palliative care, maybe they're not considered. We need to give them more emphasis. Palliative care support is psychological support. One of our contributors did say that. Palliative care, somebody said, in the form of public health nurses, care in the hospices, catering staff, care assistants, other staff, palliative care at home teams. The psychological support is very important. Somebody said the public health nurses coming in were fantastic. They gave him so much time. He found it, he was able to talk to them. I found it was very good when he was in the hospice, the support in there. Again, when we mention the staff, we see here the catering staff, the care assistants, everybody. We do say it takes a village. It takes a village. I work in the residential care setting, and I can't tell you how important housekeepers and maintenance men are in supporting things like the psychological needs of some of our residents. It's warming to see it, these compassionate communities, if you like. So, what are our expectations and acceptance of palliative care support? Some people may be resistant to receiving palliative care. They may not understand it well enough. They may associate it with end-of-life care. So there is a place for educating people about what palliative care truly is. They may perceive it as giving up at a time when they don't want to give up, but it can help in ways that they do not realize. And one of our contributors said that they're a firm believer that psychologically what kept them going was their positive mental attitude. They think there should be training, more emphasis on a positive attitude. Our minister, Mike Nesbitt, this morning said, let's not look at limitations, let's look at quality of life. And we see this in our quote as well. This contributor said, let's look at not what's wrong with me, but with what's right with me. So it was a very positive contribution here. We all go through bad times. And this person said, I almost passed away, so every day to me is a good day. So let's all live like that. So, psychological support is provided by family caregivers, but who supports them? As the family, the carer, you are the psychological support for the person receiving palliative care. One of our contributors said, I was a psychological support to him in hiding a lot of the different things from him. I tried to be upbeat around him all of the time. But I suppose, having said that, I wasn't getting the support from the groups of people that I should have been getting. I hid so much from him. And as I read this quote, I just can't imagine the strain for that person going through a very emotional journey themselves, and they were protecting everybody so well, but were feeling quite drained, I imagine. Everybody comes to see the person who's sick, and nobody gives any notice to or any care of the carer. Bereavement support would be appreciated. Again, some very sad commentary that came through here. People said they just walk away afterwards. Very few people think of making a phone call to the person, the people left behind. Somebody else said, I found socially it was afterwards that I suffered. It was in the grieving process. I felt very lonely. I have a very large and very loving family, but I didn't want to let them know how upset I was because I might upset them. So grieving is a lonely thing. And then another person said, when my loved one died, it was like everybody's job was done. They just left. It was only about a fortnight later that I finally realized I'm on my own. Even the people that came around to visit to see how my loved one was, there was no need for them to come anymore, so I was completely forgotten about. So just to be mindful here. So let's summarize. All needs are individual to each person. Communication is key in determining the spiritual, social, and psychological needs of the individual and their families. And communication is an art. Supports in all areas are likely required from early stages of diagnosis. Needs may change at different stages of life and illness. The person themselves is on a learning journey, as are their loved ones. Are we helping them to learn? Spiritual, social, and psychological supports are important not only for the person receiving palliative care, but also for their family and caregivers. And supports for the loved ones after the person has died is important. I just want to finish with Dame Cicely Saunders. She said, how people die remains in the memory of those who live on. And thank you.